So now I'm going to talk to you a little bit about our amazing speaker, Dr. Carolyn Major. She is a doctor of optometry and a fellow of the American Academy of Optometry and Optometric Retina Society. She received her doctorate of optometry from the Pennsylvania College of Optometry at Salus University and completed an ocular disease residency at the Eye Institute of the Pennsylvania College of Optometry. Following completion of her residency, Dr. Major served as chief of the Retinal Disease Clinic and assistant professor at the University of the Incarnate Word Rosenberg School of Optometry for 8 years. In 2019, she joined the Northeastern State University Oklahoma College of Optometry as an associate professor and the director of residency programs. Dr. Major's research interests include retinal diseases and OCT angiography. Thank you so much again for being here, and I'll let you take it away.
Oh, my absolute pleasure. And I want to thank Wu University for having me here this evening. Here are my financial disclosures. Of note, I am a speaker and consultant for Carl Zeiss Meditech, as well as Regeneron Pharmaceuticals, Apellis, and Nodal Vision Iveric Bio. And all my financial relationships have been mitigated. So rest assured, you'll have an unbiased presentation this evening. And so welcome everyone, good evening, and thank you so much for tuning into this lecture entitled 21st Century AMD Retinal Imaging and Diagnostics. And here's my contact information and again, my disclosures. I also posted a handout in various formats on my website here if you want to go ahead and screenshot that real quick. One of them is like full page, high resolution slides. So the images, I think throughout here, it's a lecture about imaging. So you have access to those really high resolution images. It is a large file. So I'm going to put a disclaimer on that. The one that's like 6 slides per page is not quite so beastly. And so to give you an overview and a roadmap of what I want to cover throughout tonight's lecture, first, just some basics about macular degeneration, the prevalence, the expected growth in the future. Talk about macular degeneration staging and classification schemes, which is really important when we're trying to say what's the standard of care monitoring frequency, treatment, and referral for these patients. We're going to talk especially about retinal multimodal imaging technologies, especially OCT, fundus autofluorescence, OCT angiography. Then we're going to talk about the utility of this imaging in macular degeneration. How is it going to apply to your clinical practice and allow you to provide the highest quality of care for your patients moving forward? And we're going to break that down into different classification schemes. So first, we're going to focus mostly on non-exudative macular degeneration. Talk about different drusen subtypes, which are high risk. We're talking a lot about geographic atrophy, or GA, especially since new complement inhibitor therapy has recently been FDA approved. And then we're going to talk about what are some high-risk biomarkers, especially on OCT, that we can identify that increase the risk for progression or conversion to advanced stage macular degeneration. Then we're going to focus on neovascular and exudative AMD features. And if we have time, I bit off more than I can chew. We might talk about home monitoring strategies to detect for early conversion. If not, please feel free to read that over in your handout. So by way of just gross introduction, right, macular degeneration is the leading cause of blindness in the developed world in persons over the age of 50 years old, and is the 3rd leading cause of blindness worldwide. So this is a global disease. It's characterized by pathologic alterations of the outer retina, specifically the RPE, photoreceptors, Bruch's membrane, and choriocapillaris complex. And clinically, this manifests as some characteristic features that we can identify with our examination, such as drusen, RPE pigmentary abnormalities, geographic atrophy, as well as choroidal neovascularization. And in the near future, even now really, there's this great demand for macular degeneration eye care due to the growing proportion of older adults in the United States. And in fact, the prevalence of macular degeneration is expected to increase to 22 million by the year 2050. And the number of advanced macular degeneration cases, that is central geographic atrophy or neovascular disease, is expected to more than double from 1.7 million in 2010 to almost 4 million in 2050. Only about 1/5 of all AMD cases are exudative, yet neovascularization takes most vision, right? It accounts for about 90% of severe central vision loss from macular degeneration as a whole. Multimodal imaging, especially OCT, is very useful for detecting new or recurrent neovascular activity and guiding anti-VEGF therapy. But most importantly, it facilitates our ability as the primary gatekeepers, optometric physicians, to detect the earliest exudative neovascularization possible, refer for prompt treatment when the vision is still good, and then prevent future vision loss. So let's now shift our conversation towards a really hot topic in eye care right now, which is geographic atrophy. And so geographic atrophy, we know, is characterized by irreversible tissue loss of the RPE photoreceptors and choriocapillaries. And typically, when we're using this term, geographic atrophy, it implies that the eye that has this atrophy is treatment naive, right? There hasn't been any sort of prior anti-VEGF therapy. There's no neovascularization, no exudative signs present, right? So we're not talking about the type of patient that's had neovascular exudative AMD, had a bunch of anti-VEGF injections, and is left with this like central disciform scar, subretinal fibrosis with surrounding RPE atrophy. That's not the sort of patient we're talking about. We're talking about a patient that has no neovascularization, no exudation. And studies show that geographic atrophy affects about 8 million individuals worldwide, almost 1 million alone in the United States, and represents about 20% or 1 in 5 patients with AMD. There is a substantial risk, unfortunately, for non-central geographic atrophy, or what you'll hear me sometimes refer to as extrafoveal GA, to encroach upon and invade the fovea and therefore result in decreased visual acuity. In the original ARED study, the median time from any geographic atrophy diagnosis, so extrafoveal, to when the fovea became involved was only 2.5 years. Furthermore, data from the AREDS 2 study, which is depicted on the graph here on the slide, showed that over half of eyes, 57%, that entered the study coincidentally with some extrafoveal GA suffered central involvement by the 4-year mark in the study. And if we follow this data out and this graph out to about 5.5 years at the end of the study, almost 70% of patients that entered the study with extrafoveal GA now had central involvement, which usually accompanies or is accompanied by a decrease in visual acuity. So while geographic atrophy doesn't take vision as swiftly or as aggressively as neovascular exudative AMD, it still is a rather rapid and unfortunately irreversible process that we now have a therapy for. Visual impairment from macular degeneration has a substantial functional and mental health impacts, unfortunately. But really, any retinal disease that causes vision loss is going to have mental health impacts. We know that areas of geographic atrophy correspond to really dense or absolute central scotomas, and even patients that have non-central atrophy may experience difficulties with reading, facial recognition, especially because this is taking away central vision. They can't recognize their grandchildren anymore, or they're walking on the sidewalk and a friend says hi to them and they don't recognize them and they're embarrassed, right? There's a lot of impacts on a daily level, a social level that we need to recognize and appreciate. And older adults with visual impairment are more likely to suffer from anxiety and depression. And anxiety, not only just because maybe they can't see their surroundings or interact in their environment, but anxiety over treatment, actually, and anti-VEGF injections, potentially, or injections of any sort. They also exhibit increased mortality rates and suicide rates, and perhaps due to an increased risk of falling due to poor mobility, as well as social isolation, which after COVID, we all know a lot about, and probably the mental health aspects of that too. We'll now switch gears and review AMD staging and classification. And what I'm going to present to you here in this slide is sort of my own personal mashup of the original AREDS categorization scheme, as well as the Beckman Committee classification system. So before we go through the individual stages, let's just take a step back and say, when we're considering lesions, They need to be within 2 disc diameters from the foveal center. So we're not including drusen that's like out in the arcades or in the mid-periphery, right? It has to be in the macular region. In individuals 50 years old or older, that's what we're considering in this staging classification. So our first stage is no AMD or AREDS category 1. This is no drusen or only a few small drusen present. The second category is early non-exudative macular degeneration, and this was AREDS category 2 in the original AREDS study. And this is characterized by a few less than 20 medium-sized drusen. We then have intermediate stage AMD, and I'm going to highlight this here because this is the most important stage for us as optometric physicians to recognize. And this is characterized by any one of the following features. So the first is at least one large drusen. That is 125 microns in horizontal diameter or greater. And we say, well, I'm going to like bust out my millimeter roller or whatever and measure it in clinical setting. You don't have to do that. You can estimate this by looking at a vein as it crosses the disc margin. The width of that vein is probably approximately 125 microns. Or if you're using OCT, you can drop a caliper tool and measure the size of that drusen as well to say, is it considered large? Just one large drusen, boom, gets you into intermediate stage or AREDS category 3. The second feature would be extensive medium-sized drusen, and that's 20 or more soft type drusen, or perhaps 65 or more hard type drusen. The third feature would be non-central geographic atrophy. Once it becomes central, it's then advanced AMD. So this has to be extrafoveal. And then the fourth would be significant pigmentary abnormalities. And this comes from the Beckman Committee classification, not from the AREDS categorization scheme. So intermediate AMD, I'm really focusing on it. And it's important to us because number one, this is where you're going to start considering supplementation, right? So AREDS 2 supplements, this is where you would start thinking about there's a benefit from that in those studies. This is also where you're going to start heavily performing retinal multimodal imaging, such as OCT angiography, fundus autofluorescence, in an effort to detect geographic atrophy, which now may be treatable, and also in an effort to detect neovascularization or exudation as quickly as possible so that prompt anti-VEGF therapy can be done appropriately if that's present. And then it's also important because these are patients we need to monitor more frequently. And why? Because we know the risk for conversion to advanced stage macular degeneration, which robs patients of visual acuity, is about 18%, like 20-ish% at 5-year time frame. That risk increases to 26% if there's multiple large-sized drusen present in both eyes. And then we have advanced stage macular degeneration, or AREDS category 4, which comes in 2 different flavors like chocolate or vanilla, right? So the chocolate is central geographic atrophy, and the vanilla flavor would be neovascularization. And we can further subclassify neovascular AMD into either exudative or non-exudative forms. So exudative choroidal neovascularization has exudative features, right? The vessels are leaky, incompetent. They leak out fluid, they leak out blood. There's leakage present on IV fluorescein angiography. The second type would be non-exudative choroidal neovascularization, which may actually be a good thing in some instances. We'll kind of talk about that a little bit. But this is choroidal neovascularization that's composed of vessels with non-permeable walls. So they're competent vessels. They are not associated with any sort of leakage on fluorescein angiography. There's no OCT fluid, there's no hemorrhage or exudate on fundus examination. And this term, non-exudative choroidal neovascularization, typically also implies that this eye is treatment naive, so there's no prior anti-VEGF therapy given. We can then further subclassify exudative macular degeneration into active and inactive forms. So the active exudative AMD form typically requires treatment, especially on initial detection in an eye with good vision, versus inactive exudative macular degeneration refers to an eye that's been successfully treated with anti-VEGF therapy in the past, such that no fluid remains when you do OCT. And typically these are patients that have some sort of like disciform or subretinal scar in the macular region. And I think a really important point that we put here is a patient that has neovascular AMD in one eye where the fellow eye is still non-exudative or non-neovascular. Those are patients you need to watch like hawks, right? Very, very closely, because the risk for that non-exudative eye to go on and develop neo, just like the fellow eye did, is about 50% or 42% at 5 years. And then I included this in your handout. So this is the original table from the ARED study that has their different categories, just a little bit more complex to understand, I think, than what I probably presented to you. But if you want to go back to the original source, there it is. So I want to review some of the primary screening methods for detection of both exudative macular degeneration as well as geographic atrophy. And one really important one is OCT. So we're going to go through some of the basics and reviewing OCT anatomy as it relates to the outer retina and macular degeneration. So some of the outer retinal layers we want to be familiar with is this hyporeflective or dark layer that's easy to identify because it's at the very base of the center of the fovea. It's one of the thickest layers within the retina, which is the outer nuclear layer that represents photoreceptor cell bodies. We then have a series of 4 hyperreflective bands that represent the photoreceptor RPE Brooks membrane complex. The most anterior thin hyperreflective band is the external limiting membrane. The one right below that is arguably the most important. It's the ellipsoid zone, or its former alias was the ISOS junction, photoreceptor integrity line, the pill, I don't know, it goes by a lot of different names, right? It gets a lot of street cred. But this I'm going to refer to as the ellipsoid zone, which we believe it to be, is most consistent with visual acuity and visual function in most retinal diseases. So it represents photoreceptor integrity and function, this ellipsoid zone. Moving on down, we then have the COST line, the COST, which stands for cone outer segment tips. So literally the tips of photoreceptors as they interdigitate with the RPE is what we're visualizing there. And then the most posterior bright hyperreflective band represents the RPE. We know that underneath the RPE is Brooks membrane, right? But typically we cannot visualize Brooks membrane because it's a butt of the RPE. However, when we have a patient, say, with a pigment epithelial detachment or just sick RPE like this, that's kind of peeling off Brooks membrane, then we can visualize it. And it's a thin hyperreflective band. And I'd say like the thinness is comparable to the external limiting membrane. An inherent challenge of OCT data analysis is finding a way to display this, awesome volumetric cube of 3D data that we get in a 2D format that's easy for us to kind of quickly look at, analyze, and understand. So one solution is to view in-FOS images rather than having to scan through the whole cube. So an in-FOS image represents a slab of data, like several retinal layers compressed down into a 2D plane and then turned in FOS for us to view in a 2D format. And in-FOS analysis can be used to view both structural and angiography OCT data. In fact, in-FOS analysis and displays has been around for a long time for structural analysis. It just wasn't used a whole lot. It is going to be a very important way that we view geographic atrophy growth over time, and I'm going to highlight that here a little bit later in the lecture. But it gained a lot of popularity when OCT angiography came out, because in-FOS analysis is one of the main ways that we view OCT angiography data. Let's shift gears and talk specifically about OCT angiography. So this is non-invasive, dyeless, no dye injection required imaging technology that again provides us with these volumetric 3D maps of data of retinal vessels as well as information on blood flow. And despite the name, it's not truly a form of angiography, right? Because we're not doing a dye injection. We're not watching where dye travels over time. Rather, this is a tool that allows us to visualize a snapshot of red blood cell motion at the time the scan was taken. The interpretation is really simple when you keep working with it, right? So dark areas are probably areas of decreased perfusion or non-perfusion versus bright areas likely represent areas of fast, heavy blood flow. A very important basic concept to understand about OCT angiography is that we can't capture slow extravascular flow of clear fluid, right? So for that reason, we cannot image leakage, which is a characteristic feature of active neovascularization with fluorescein angiography. And this absence of leakage is in some ways a benefit in the sense that it doesn't obscure our view of neovascular membranes. So we get really nice, high detailed views of membranes that allow us to classify their morphologic patterns and also precisely measure the size and say, is it getting bigger over time or hopefully regressing over time? Similar to a conventional just OCT macular cube scan, angiography gives us this nice volumetric cube of data, which is of such value to us because we're able to isolate out perhaps the particular capillary system. Say, I only want to look at the choriocapillaris. And the beauty of having this volumetric data set is that it allows us to isolate abnormal vessels, right? I only want to look at the area where I know choroidal neovascularization or subretinal neovascularization is going to grow because I need to identify that and refer, right? This is what it helps us do. Additionally, OCT angiography allows us to visualize conventional structural data as well as angiography data side by side, and then draw important conclusions about when we have structural fluid, where that fluid may be coming from, perhaps this vascularized pigment epithelial detachment. One of the preset and FOSS displays on OCT angiography that I want to highlight for outer retinal disease is the outer retina is what like the OptoView calls it versus the outer retina choriocapillaris is what Cirrus models call it. And so this preset, the outer retina or outer retina choriocapillaris is where it's at with regards to macular degeneration and really where you want to focus your attention. So this was specifically designed to assist you in detecting subretinal and choroidal neovascularization. The name and the segmentation boundaries depicted in yellow here typically include the outer photoreceptors or the outer retina, the RPE, as well as the very anterior choriocapillaris. And we're trying to intentionally detect areas of neovascularization with this slab. So really important that you focus on the outer retina choriocapillaris preset and FOSS display when you're trying to use OCT angiography to visualize early neovascular macular degeneration. We can also view flow information superimposed directly upon our conventional structural OCT cross-section scans, right, in red. So here we have two pigment epithelial detachments. One is vascularized and one is not, right? So other ways that we can just view this data. Let's switch gears now and talk about fundus autofluorescence or FAF. So fundus autofluorescence, you can think of it as a metabolic map of the RPE and photoreceptors, essentially. How much lipofuscin or like A2E is present in the outer retina in RPE that we're able to visualize with this autofluorescence signal. So areas of hyper autofluorescence are sick RPE. Impending death is coming probably for these hyperfluorescent areas. So this may represent areas of chronic subretinal fluid where the photoreceptors are disrupted in some way. Then areas of darkness or hypoautofluorescence, these are areas of RPE loss or atrophy. It's already gone and dead away so that there's no lipofuscin present in the RPE in that particular location. Also keep in mind that there might be dark areas due to blockage. Like let's say you had a preretinal or subretinal hemorrhage, that's going to block your view of the fluorescence of the RPE underneath that area of blood. And then this is a wordy slide. I apologize, but like an overview, I think, of the benefits of each imaging technology as it applies to macular degeneration. I'm not going to read this to you. We're going to go through some visual examples. You're like, oh, thank goodness. Right, so the first thing I want to talk about is using OCT to subclassify drusen types, which we know has significant prognostic value. So we can classify drusen as hard, soft, or we call subretinal drusenoid deposits, or reticular pseudodrusen. Now we know now that both soft drusen as well as reticular pseudodrusen or subretinal drusenoid deposits are both high-risk subtypes of drusen that predispose a risk towards converting to the advanced stage of macular degeneration in the future. Now, certainly, like large soft drusen, we knew for a long time was a risk factor for progression. But more recently with OCT, we now understand that these subretinal drusenoid deposits are also high-risk variant of drusen. So let me just talk through the OCT features of both. So soft drusen are these large, round, and relatively hypo-reflective internally elevations of the RPE. So look how nice and round and smooth the surface contour of this drusen is. Versus subretinal drusenoid deposits are these nodular hyperreflective deposits that rest on top of the RPE, right? So here's the RPE underneath, and it's kind of cutting through your ellipsoid zone. We know that eyes that are just lucky enough to have both subretinal drusenoid deposits as well as soft drusen, so both high-risk drusen variants are at the greatest risk to convert to exudative or neovascular AMD in the future. Enhanced depth imaging on OCT in eyes with AMD shows us that the subfoveal choroidal thickness is thin compared to eyes that don't have macular degeneration, and it gets thinner and thinner as the stage of macular degeneration progresses on. And these findings really suggest, I think, that there's probably some choroidal ischemia, a component that is causing the pathogenesis of macular degeneration, probably both AMD, but also fueling VEGF release and neovascular growth. Looking at the choroidal thickness, what's the point of looking at it, right? I think there's a point when you're trying to determine, is this AMD or is this pachychoroid disease like central serous choroidoretinopathy, right? So look at the thickness of the choroid. If you have a patient with 50-year-old patient with a serous retinal detachment, if the choroid's thin, you might be leaning more towards this might be AMD, especially look for drusen and other signs of AMD. If the choroid is thick, right, then you might be thinking, oh, this might be pachychoroid disease, and they're managed quite differently. And the prognosis is different too, right? So let's now focus our imaging discussion just on geographic atrophy, right? And optometric physicians will definitely need to be more vigilant, in screening for geographic atrophy moving forward to ensure that patients that could potentially benefit from these newly approved complement inhibitor GA intravitreal therapies are identified in our office and then referred appropriately. So a multimodal retinal imaging approach, especially including fundus autofluorescence, OCT, those are the two primary methods for us to detect and monitor GA over time, is very important and is your optimal way to detect and measure growth of GA over time. Color fundus photography alone just isn't good enough. And I'll show you some examples here in a second. That's an ineffective way at detecting early geographic atrophy. So the classification of atrophy meetings group, or this CAM group, right? It was a group of experts, like a panel of retinal specialists that came together and said, we need to define what are the features of geographic atrophy on OCT imaging. And they came to this conclusion as well, that a multimodal imaging approach is optimal for the detection and measurement of GA. So geographic atrophy on color fundus photography appears as a hypopigmented area with sharply demarcated borders, but color photography is really ineffective at detecting early geographic atrophy. Let's compare this with fundus autofluorescence, right? So fundus autofluorescence is one of the primary methods, along with OCT, that you're going to use to detect and monitor geographic atrophy over time. So on fundus autofluorescence imaging, geographic atrophy is a well-demarcated, so these nice pristine borders, a dark or hypofluorescent area due to loss or death of the RPE. And as demonstrated here visually, fundus autofluorescence is more sensitive than color fundus photography in identifying early geographic atrophy. Another way that we can visualize geographic atrophy that's probably less commonly used or maybe just not as well known about, but to be honest with you, I didn't think much about it until these geographic atrophy medications came out, is near infrared reflectance or NIR imaging. You may think, well, what is this? Do I have to have like a near infrared camera or something like that? No, if you have an OCT, when you take like a raster OCT on the side, you get that like grayscale image. That's a near infrared reflectance image. So you probably have access to this and just didn't notice or pay much attention to it, but it is of value in looking at geographic atrophy and can be used to track geographic atrophy progression over time. And so on near infrared reflectance, geographic atrophy, is going to be a bright hyperreflective area, which is the exact opposite of what I just told you on fundus autofluorescence, where the geographic atrophy is dark, right? So in the words of the great Missy Elliott, if you grew up in the 1990s, right, you have to put your thing down, flip it, and reverse it, right? So on near infrared reflectance imaging, GA is going to be bright. On fundus autofluorescence is going to be dark. On cross-sectional, just conventional structural OCT, geographic atrophy is characterized by the loss of photoreceptors, RPE. And by definition from this CAM study group, they're saying it has to be the loss of photoreceptors and RPE, at least 250 microns in diameter with corresponding homogeneous choroidal hypertransmission. So remember, our OCT light source is light. We're using light waves. And when we lose the RPE, light can penetrate down through into the choroid, which is what we're visualizing here. So this homogeneous choroidal hypertransmission is another feature of geographic atrophy. I like to think of it sort of as like light, like shining through a window. Another way we can visualize geographic atrophy, which is one of my preferred methods, and I think makes it very simple for you, and sometimes can incorporate quantitative data depending on the OCT system that you have, is in-phos analysis. So one way to use in-phos analysis to image geographic atrophy is what we call a sub-RPE slab. And what we're trying to do is actually map out this choroidal hypertransmission in a 2D format, right? So imagine we take an NFOS slab just underneath the RPE. We're catching these areas of hypertransmission and viewing them in a 2D format like this. So the geographic atrophy is going to look bright on this sub-RPE NFOS slab. We can also just do a NFOS slab through the ellipsoid zone of the photoreceptors. We know photoreceptors are also lost in geographic atrophy, and also visualize it in that manner as well. OCT angiography is going to show you loss of the choriocapillaris in areas of geographic atrophy that will allow you then to see down through to these larger choroidal like vessels and Salers and Hadler's layers, right, that we usually don't see. And at first glance looking at it, you may think, oh, this is a choroidal neovascular membrane, but put this in perspective, right? This is a hypertransmission defect or choroidal hypertransmission. We know that looking at the cross-sectional scan because we have choroidal hypertransmission, number one. We also know that because we have tissue thinning or tissue loss, right? The retina is thinner than we would expect it to be. Versus if it was truly choroidal neovascularization, we would expect the retina to be edematous or thicker. There'd be some subretinal hyperreflectivity or something. The retina would be thicker in that region if it was truly neovascularization. So use those cues to help you know whether you're dealing with neo versus just transmission from geographic atrophy. The development of atrophy is really a complex process that we're just beginning to understand truly, that evolves from earlier stages to an end stage of this complete RPE and photoreceptor loss. So there are many ways that you can develop geographic atrophy, and every patient's probably a little bit different, unfortunately, just to make our job a little bit more confusing. You could have the collapse of large soft drusen-formed geographic atrophy, or you could have patients lose the RPE, then the photoreceptors go after. Or some eyes, you'll have loss of photoreceptors followed by RPE atrophy. So every patient's a little bit different. And that CAM group, the Classification of Atrophy Meetings group, remember they set out to say, what are the OCT features that define full-blown geographic atrophy? Patients that really should be included in these clinical trials for these upcoming medications, right? It was their goal of doing this research. And so what they called complete RPE or outer retinal atrophy, or for short, we're calling it CRORA, is a term you're probably going to hear more and more of in the future. And as I mentioned before, they're defining this as an area of photoreceptor and RPE loss at least 120-50 microns in diameter with corresponding homogeneous choroidal hypertransmission. They also defined OCT features consistent with impending or nascent geographic atrophy. And these lesions, then predisposed to future geographic atrophy development. And they called this incomplete RPE or outer retinal atrophy, or IRORA for short. And so IRORA is characterized by photoreceptor attenuation that results in like sinking or subsidence of the outer plexiform layer towards the RPE with corresponding attenuation of the RPE. We'll look at some more examples here in a minute. So high resolution OCT affords us this great opportunity to identify the early stages of the atrophic process before geographic atrophy is even clinically visible as detected by fundus autofluorescence. So let's review some of the important high-risk OCT features that are going to predict or predispose patients to geographic atrophy in the future. The first is subsidence or sinking of the inner nuclear layer and the outer plexiform layers posteriorly, right? If we have atrophy of the photoreceptors and RPE, loss of tissue, the overlying outer nuclear layer and outer plexiform layer just sink down into that pit, essentially. And they form this so-called gull wing configuration. As you can see, the outer plexiform layer kind of looks like seagull wings, I guess. This is more of like a mental test than how do you interpret OCT test, really. And similarly, the external limiting membrane may also descend or like curve downward towards that area of tissue loss. You can also visualize loss of the ellipsoid zone and the external limiting membrane integrity, which is evidenced on OCT as this discontinuous or decreased intensity of the ellipsoid zone band. Another example here of ellipsoid zone loss. So early photoreceptor loss, but the RPE still looks pretty intact. So some early stages. Hyporeflective wedges are another sign of impending or nascent geographic atrophy. So there are these triangular shaped hyporeflective regions where the base is at the RPE and the apex kind of extends upward, and they usually come in pairs. There are also like drusen variants that we can identify as risk factors. One of those is drusen that have hyporeflective or dark cores internally. Another is hyperreflective crystalline deposits or sub-RPE plaques. So these are hyperreflective linear lesions in the sub-RPE space on OCT, but clinically both drusen with hyperreflective cores as well as these sub-RPE crystalline plaques appear clinically as reflectile drusen, or you might sometimes hear like crystile type of drusen. Let's now switch gears and talk about imaging features that, if found on the border of already existing geographic atrophy, are associated with an increased risk for progression and enlargement over time. So one of those features is splitting of the RPE up off of Bruch's membrane. We know that this feature corresponds to sick RPE on fundus autofluorescence, or a bright area of hyperautofluorescence surrounding the geographic atrophy margin. So sick RPE versus intact RPE, that's going to be relatively more stable. The GAIN study was a really important study that found that there's substantial prognostic value in various geographic atrophy phenotype fundus autofluorescence patterns. So we know that geographic atrophy with a continuous band of hyperautofluorescence surrounding it, or where almost the entire posterior pole is diffusely hyperautofluorescent, is at risk for enlargement over time. High risk phenotypes, right? There's a ton of sick RPE in the posterior pole versus individuals that have perhaps no fundus autofluorescence on the margin, hyperfundus autofluorescence on the margin, or maybe only have a few little like focal patches on the margin, are less likely to progress or enlarge over time. So let's kind of incorporate everything we learned now into a case and see how we go through this process of developing geographic atrophy. So this is a 60-year-old female who initially came in without complaints, pretty good vision, like 20/25, 20/30. Centrally in both eyes, we can see there are large confluent soft drusen. They're large, they have these fuzzy borders associated with them, these indistinct borders. On OCT, there's a classic soft drusen appearance where we have these large round-shaped elevations of the RPE. Another type of drusen we see here, though, is kind of out in this paramacular area. These small, discrete, whitish-yellowish clusters of dots represent reticular pseudodrusen or subretinal drusenoid deposits. And we can start to visualize one on OCT here. Take note, always, right? So remember, we were talking about GA because it's hot and whatever right now, but don't forget about what causes 90% of blindness from AMD, which is neovascular and exudative disease. So take a step back and say, we need to make sure that there's no exudative or neovascular features present as we're going through every patient we see with AMD, right? There's no fluid, there's no hemorrhage, there's no exudate, there's no grayish green subretinal thickening, right? Irregular fibrovascular PEDs, etc. We don't have anything like that. And then here are two different raster scans going through the macula of the right eye. And just to highlight for you that she has these two high-risk variants of drusen, unfortunately. So these large soft drusen, as well as these subretinal drusenoid deposits. Looking at the right eye now, been fortunate enough to follow this patient over the course of 5.5 years, so relatively long follow-up on her. And at the 4-year mark, you can see that she developed some high-risk OCT biomarkers for progression, which first are hyperreflective foci. So these represent migration of the RPE anteriorly or intraretinally. We can also see it on fundus color photography as these hyperpigmented areas that usually sit on top of large soft drusen. Another high-risk feature that she now has are these sub-RPE hyperreflective columns, or these sort of vertical lines of hyperreflectivity on OCT that's telling you that RPE is compromised, right, and may die off over time. At the 5.5-year mark, she now develops clearly what is nascent geographic atrophy. We have loss of the photoreceptors. We have these hyporeflective wedges. We start to see some hypertransmission down into the choroid, so impending geographic atrophy. And let's step back and look at the color fundus photography here for a minute. Where she had this large soft drusen that then forms some pigment clumps, and then the drusen disappeared, right? So the drusen regressed. Drusen regression is a bad thing, right? You think, oh, the AMD is getting better, the drusen are going away. Unfortunately, that's a sign that's telling you this patient is probably going to convert to the advanced stage of disease, whether it be geographic atrophy, as we see here, or neovascular exudative AMD. And here is OCT and FOS analysis, where we're specifically looking at maps, heat maps of RPE elevation, visualizing that drusen regression that's occurring over time as she goes on to develop geographic atrophy. This is the sub-RPE analysis, or in-FOS OCT. So we're looking at choroidal hypertransmission in a 2D format, essentially. And then we also get trend analysis with this as well. So we can see the collapse of this large drusen, right, that forms geographic atrophy. Over time, here we start to see this little area of geographic atrophy form, and then it kind of clusters into multiple areas and enlarges over the course of this particular analysis. If we looked at the trend, right, so this actually gives us quantitative data that I can use to measure the area of geographic atrophy over time. So this is the total area encompassed by these like black lines right here, right? So the GA area is increasing, so she's progressing. I can also measure the closest distance to the foveal center, which is like a little red line. You can't see it really here because she basically becomes center involved very quickly in the course of geographic atrophy development, unfortunately. Her left eye, almost identical course to the right eye, very symmetric progression. So we have collapse of these large soft drusen. At 4 years, she clearly has nascent geographic atrophy. We can see that subsidence of the outer plexiform layer, choroidal hypertransmission. And then at 5.5 years, undoubtedly has a small round area of central geographic atrophy. Here's the fundus autofluorescence at the end of 5.5 years. So remember I said your two primary methods for assessing geographic atrophy, fundus autofluorescence and OCT. We just looked at the power of OCT in this case. Let's step back and look at the fundus autofluorescence, right? So the right eye has these multifocal patches of geographic atrophy. We can also very nicely see now this reticular pseudodrusen that's present in this individual, as we pointed out on the OCT earlier. And then she has this central area of GA in the left eye. So let's take a step back and briefly talk about emerging therapies for geographic atrophy, or one, I guess, has already emerged and more are to emerge in the future. Let's say it that way. Really important concept to understand. It does not improve vision. We do not stop progression of geographic atrophy. We slow it down. So think of it much like glaucoma treatment, right? We're just buying the patient a couple more years of good vision, right? That's similarly what we're doing here. We slow the progression, we do not halt it. So patients undergoing therapy, which can be somewhat brutal, right? We're looking at intravitreal injections either every month or every 2 months, should have the expectation that my vision is still going to continue to get worse. But it's not going to get as worse as fast as it would have been if I hadn't been undergoing treatment, essentially, right? Buying a couple more years before the geographic atrophy invades the foveal center and acuity declines as a result of that. So these complement inhibitor therapies are all administered, well, currently via intravitreal injection. One of them, pegcetacoplan or Syfovre, was just FDA approved in February of this year. Their phase 3 clinical trials were the Derby and Oaks. There's another one where they've submitted to the FDA and they're waiting for approval pending by August of 2023. Their phase 3 trials, Gather 1 and Gather 2. And this is from Iveric Bio, and I think they're going to do a presentation after I'm done here if you want to learn more about their therapy, which will likely become FDA approved here shortly. So let's focus a second on the newly approved FDA medication, pegcetacoplan, and look at the 18-month combined results from these phase 3 trials for the Derby and the Oaks. So within this study, they enrolled patients that, number one, did not have neo, did not have exudative disease, right? So they solely had geographic atrophy. They had to have good vision, right? You have to have good vision to enroll in the study. So 20/320 or better. You had to have geographic atrophy total area of at least 1 disc area. In this study, they did enroll patients with both central or non-central extrafoveal geographic atrophy. They also had to have some pattern of hyperautofluorescence on the margin of the junctional zone of geographic atrophy to indicate that they're probably going to progress or enlarge over the future. The primary endpoint in the study was they were looking at the change in geographic atrophy over time using fundus autofluorescence. And what they found is that there's approximately a 6% reduction in the growth of geographic atrophy with monthly treatment when it's extrafoveal compared to sham treatment. And this is better than foveal-involved GA, where we only got about a 13% decrease in growth rate at 18 months. So extrafoveal GA, better effectiveness with these new therapies. If we look at 24-month data and the cumulative incidence of neovascular AMD, there was a dose-dependent effect in the incidence of choroidal neovascularization. So in sham at 24 months, about 3% of patients developed neovascularization. If we follow this out to monthly injections, it's about 12%. So it's slightly increased the risk of developing neovascularization. It is therefore critical for us to recognize that patients undergoing therapy with geographic atrophy complement inhibitors have a risk to still convert to the exudative neovascular form of the disease, in which case they would then probably undergo both intravitreal complement inhibitor therapy as well as anti-VEGF, right, on different days, but dual therapies for these eyes. So vigilantly monitor for conversion of exudative disease, even in patients undergoing geographic atrophy therapy. So I want to present to you some of my opinions based on my own personal analysis of this phase 3 trial data, the inclusion-exclusion criteria from these trials, In my discussions in talking with retinal specialists and other experts in the field as to what patients do we think are going to benefit most that you should refer for some consideration of geographic atrophy treatment, right? So extrafoveal geographic atrophy, especially those that exhibit growth over time and you have evidence of progression, send that with the patient to the retina specialist. So the retina specialist knows this GA has been demonstrating growth over time and may benefit from therapy, right? Especially if the fellow eye has central geographic atrophy. That's even more risk and more motivation from a patient perspective. They know what it's like to have GA involved with center fovea and decreased acuity in one eye. They're going to be highly motivated to save the fellow eye. The patients that are willing to undergo intravitreal injection at least every month or every 2 months, which is the FDA approval, so they have to be willing to do that. And patients that have enough life to live to experience benefits. If we look again at the clinical data, it takes about a year or two before you start to see a significant benefit. So if you do just one injection, right, you're not getting any benefit. So they have to have some sort of lifespan in order to potentially benefit from this therapy. Those that are unlikely to benefit and probably shouldn't be referred to a retina specialist. If they have neovascular exudative AMD or a history of anti-VEGF therapy in the affected eye. It's okay if the fellow eye is neovascular, but the affected eye that you're intending to maybe treat with geographic atrophy therapies should be completely dry, no neovascularization. Patients that have discoform macular scars following anti-VEGF therapy usually have decreased vision, a history of neo, that's probably not a good patient to refer. Those that have extensive geographic atrophy, where the best corrected acuity is already tanked, say like count fingers, there's nothing left to save, unfortunately. That patient's too far gone at that point. For this therapy, certainly low vision, I think, can be very beneficial. So other things. Patients that have RPE atrophy from other causes, like adult onset foveal vitelliform dystrophy or adult onset Best disease, inherited retinal disease. Again, these were not patients that were included in these clinical trials. Use of complement inhibitors would be considered off FDA label. And I want to present a case of, I think, the ideal patient to benefit from these new geographic atrophy therapies. So this is an 81-year-old female, and she's complaining of progressive decrease in vision in both the left and the right eye, but the left eye being worse. And so we can see in the left eye, she already has central involved geographic atrophy with 2100 vision. Her fellow eye, right, she has sort of this like U-shaped or paracentral ring of geographic atrophy with relative central sparing. Visual acuity here, because the center is relatively spared, is good, 20/40. So this is worth saving, worth keeping. Here's the serial color fundus photography over the course of 2.5 years here in the right eye. You can see the vision doesn't change despite the geographic atrophy seems to be growing, but it's hard to tell because of color fundus photography is not a sensitive way to visualize geographic atrophy. But if we look at her in-fos OCT, the sub-RPE slab, we can see even over the course of just 1 year of these studies, it's enlarging, right? So we have progressive geographic atrophy with relative central sparing. So there's still good vision here to save. This patient's going to be motivated because she's already lost vision from GA, from central involvement in the fellow eye. So she wants to save this eye as well. Let's skip through this case and go through a slide of exudative features. I'll make sure we at least spend a few minutes. I have left. Oh, I have like 1 minute talking about exudative or neovascular AMD features. So hemorrhage on color fundus photography, fluid, which OCT is best to detect fluid at any level, right? Sub-RPE, intraretinal, subretinal fluid, any fluid should concern you. Exudate on fundus examination, pigment epithelial detachments that are serous in nature, hemorrhagic in nature, are irregular in surface contour, or have variable internal reflectivity should concern you that this could be neovascularization, as well as frank OCT angiography membranes with OCT angiography imaging. So all high-risk features, red flags of patients that could benefit potentially from anti-VEGF therapy that you must refer promptly. Again, the referral time frame for neovascular or exudative AMD needs to be like within 1 week, right? That's fast when you first detect it. Geographic atrophy, there's some more time on our side. It's still rapidly progressive, but not nearly as urgent of a referral as is exudative and neovascular AMD. So make sure you don't miss it. Still be looking for it. And with that, I would love to take some questions. I'm going to go to the final slide here and pull that up. Really appreciate you guys taking the time to join me here this evening. So the take home is hopefully now you love multimodal retinal imaging as much as I do. It's going to play a huge role moving forward in detecting geographic atrophy, monitoring progression over time. It has already been an absolute game changer with regards to the detection and early treatment of anti-VEGF therapy of neovascular and exudative disease.